Empezamos.
Buenos días a todas y todos. Es un gusto para mí estar con ustedes y darles la bienvenida a la segunda conferencia de este ciclo del Seminario Web Salud Mental e Intervenciones Emergentes. Y en esta ocasión nos acompaña una invitada que nos da muchísimo gusto que haya aceptado participar en este evento, la doctora Miriam Lommen, de la Universidad de Groningen en Holanda. Y pues bueno, nos da muchísimo gusto que ella esté con nosotros participando en este ciclo de conferencias que, como les comentaba la vez pasada, es importante para nosotros tener un abordaje de lo que, pues bueno, ahora conocemos y estamos mirando de las afectaciones en la salud mental, pero desde diferentes aristas, no solamente desde la evaluación, sino también de la intervención. Y en esta ocasión nos toca hablar de un tema muy interesante que tiene que ver con justo la vulnerabilidad al desarrollo del trastorno por estrés postraumático. Y en ese sentido, bueno, pues nos da muchísimo gusto tener una experta en el área que nos va a compartir, bueno, pues sus avances, los hallazgos más importantes que ha encontrado en su investigación, y agradecemos muchísimo que esté con nosotros. Dr. Miriam, it's a pleasure to join us in this webinar. On behalf of Faculty of Higher Studies Iztacala of National Autonomous University of Mexico, we warmly welcome to our second webinar, Mental Health Assessment and Emerging Interventions. Thank you for sharing with us your findings about the interesting topic focusing on vulnerability to PTSD. It's a very interesting topic for our cultural context. Now, Alejandrina will be our session chair. So if you want to begin, Alejandrina, thank you again to be with us, Dr. Miriam.
Thank you. Well, hello and welcome to another conference in the webinar Mental Health Assessment and Emerging Interventions. It's a great pleasure for me to introduce our speaker today, Dr. Miriam Lommen. Dr. Lommen is an assistant professor on a tenure track at the Department of Clinical Psychology and Experimental Psychopathology of the University of Groningen in Netherlands. She also works as a cognitive behavioral therapist at an outpatient mental health care setting. As a scientist practitioner, she divides her time over research and teaching. Her research focuses on trauma and anxiety, in which she combines clinical and experimental research to gain more insight in individual differences that make one vulnerable to develop trauma-related or anxiety-related pathology. Her research also focuses on the treatment of post-traumatic stress disorder and anxiety disorders, aimed at identifying mechanisms that are responsible for treatment efficacy. Furthermore, she is involved with development and training of adaptations of cognitive behavioral therapy in non-Western countries, mainly Indonesia and India. Dr. Lommen is going to be sharing a presentation titled Vulnerability to Post-Traumatic Stress Disorder. Thank you, Dr. Lommen, for joining us today. And without any further ado, I leave you with Dr. Lommen.
Thank you so much for this beautiful introduction. I'm very honored to be speaking here today, and so it's a great pleasure to do this. And I'm just impressed by how professional this all works with the whole YouTube channel. It's really nice to do this. I'm going to share my screen now, so just give me a sec, please. Okay, and then I won't be able to see you anymore or to see the chat box, but we agreed that Alejandrina will also help me with the questions whenever there's something coming in. And we'll have some time at the end of the talk to also answer your questions. All right, so this should be working. So as already introduced, I'm going to talk about vulnerability to post-traumatic stress disorder, which I've been doing research on for quite a long time right now. So I like to start big, looking at the whole world. I mean, I love our world. I love traveling. I love seeing more of this world. And in the meantime, you know, we also know that traveling now is very difficult due to the pandemic. So we know lots of negative things, lots of trauma happens on this world as well. So not only as part of the pandemic, but every day there's terrible things happening. There's earthquakes, there's terrorist attacks, there's car accidents, there's tsunamis, there's like so much going on in this world, so much negativity as well. And what we know is that what you could develop after going through a traumatic event, you can actually go on and develop post-traumatic stress disorder. And one of the symptom clusters that includes post-traumatic stress disorder, for those who are not familiar with it, I'll just go through it very quickly, is re-experiencing symptoms. That means that you could have nightmares about the traumatic events. You could have intrusions where you think about or suddenly have vivid images again about the traumatic events, which are highly upsetting. But also you see avoidance of anything that kind of reminds you of a traumatic event. It could be people, could be places, could be anything that reminds you of the event. Then you also see negative alterations in cognition and mood. And finally, you see alterations in arousal and reactivity, which often shows in irritability or outbursts of anger, also concentration problems, sleeping problems, and heightened arousal. So your body is very responsive of any kind of sound and stuff like that. So that's basically the background, what PTSD contains. Interesting enough, though, is that almost everyone experiences these kind of traumatic events or these kind of symptoms after a traumatic experience. And most of us will actually experience a traumatic event in our lives. And most people recover also naturally within the first few weeks after going through such a traumatic event. However, for about 10% in men and 18% in women, these symptoms remain for longer than a month, and they might go on to develop post-traumatic stress disorder. So in a Dutch study, we found that about 7.5% develops PTSD in their life. So the lifetime prevalence is 7.5%. Knowing that most people actually experience a traumatic event, you see it's only a minority who goes on to develop PTSD. And this is what fascinates me so much. And I like this picture because it nicely represents my fascination. So really bad things can happen to you, and it makes total sense that you're on this dark side of the world and seeing the world as a very dark, negative place. Nevertheless, most of us will go back to this like green side where everything looks very beautiful, and they manage to get to the other side again. However, for some people, they don't manage to go to the green positive side again. And my question that fascinates me and has been driving my research so far is, why do some people develop PTSD after experiencing a traumatic event while others do not? So I'll take you through a few lines of my research, and I'll give you a few examples of the studies that I've been doing. And one line of research is looking into individual differences in vulnerability. So basically the question, who is vulnerable to go on and develop PTSD after going through a traumatic event? Then another line of research I'm interested in is on examining the pathogenic mechanisms. So how does that work? What kind of mechanisms are involved? Then the third line of research is basically more on the interventions. So looking into already existing interventions, for example, and trying to identify the elements that are important for the efficacy of the treatment. Sometimes also looking at new treatments, but mainly looking at the treatment package as a whole. So what makes it effective? And then the fourth line of research is cross-cultural clinical psychology, because we can put all of this into perspective of the a global perspective. And I think this is a very important area that hasn't been researched so much before. And that's why I particularly like this collaboration with the University of Groningen and UNAM have set up now. Because if you look at research so far and the empirical evidence, most are based on research in Western countries, at least in people who are predominantly white, who predominantly Western, from Western culture. And I think this is really a gap in the literature. We don't have enough studies yet in non-Western countries. And I think it's a wrong assumption to think that all mechanisms and everything that we find is just simply generalizable to the rest of the world, and that we have this kind of universality of everything that we find. So I believe it's very important to do this kind of cross-cultural clinical psychology, and I think there should be more emphasis and more attention and more money going to, basically. All right, so I'll take you through a few lines of research, and I'll show you a few of my studies and the outcomes of it. I mainly focus on already published work, so you can also read it yourself if you're interested in it. So I'll start with individual differences in vulnerability. So who is vulnerable? And for this, I'll take you through a little bit of a theoretical background of this. So when I'm looking at PTSD, one of the perspectives I've taken to understand PTSD is the learning perspective. Basically, this is just Pavlovian conditioning, right? It's classical conditioning where originally neutral stimulus in this example, that's a car, gets associated with an unconditioned stimulus, in this case, in a car accident, which elicits an unconditioned response, a fear response here. Well, what then happens is that the neutral stimulus is now becoming a conditioned stimulus, which evokes the U as expectancy. It evokes the expectancy of the accident happening again. And it also evokes the memory representation of the unconditioned stimulus. And with that, or as a consequence, the conditioned response also is elicited, this fear response. What we know is that you can learn a fear, but you can also unlearn it. This is what we call fear extinction learning. So if the conditioned stimulus is no longer paired with the US, with the unconditioned stimulus, then this conditioned response will also fade. However, what we see here in PTSD, I'm just going back on one slide forward. So basically what we know is that this fear association doesn't really disappear. We know from research now that we have these competing associations in our brain. So we have the threat association, which is also called excitatory learning association, and we have a safe association, which is also called inhibitory learning association. So we've got the safe and the danger association both there, and it's basically a matter of which one is the strongest to know what our conditioned response would be, what our response would be. And what you often see after, a bad learning experience is because if you have good experiences afterwards again, that this one, the inhibitory learning association, is stronger again and takes over. However, what we see in PTSD, we still see this fear reaction, and we see that this threat association is still predominant. So fear extinction, where the inhibitory learning association takes over and gets stronger, fails in people who suffer from PTSD. And this reduced fear extinction or failed fear extinction is prevalent in anxiety patients when compared to controls, healthy controls. And it's also shown that PTSD patients show reduced fear extinction compared to trauma-exposed controls without PTSD and non-trauma exposed controls. Well, and you could ask yourself the question, is this poor extinction learning, is that a consequence of PTSD, or is it rather a vulnerability factor? And it kind of makes sense, right, that it would be a vulnerability factor. I mean, if you're bad in unlearning a fear, then it totally makes sense after a traumatic event, which is a very intense learning experience, that it's hard to unlearn that fear, and therefore, people are, in general bad in unlearning fears, that after such a learning experience as a traumatic event, that they will go on and develop PTSD. However, the empirical evidence is very scarce so far. So there's been two prospective studies. 1 in 67 firefighter cadets, where they showed that reduced extinction learning measured through EMG responses predicted PTSD symptom severity 2 years later. Then I did a study during my PhD in 214 soldiers, and I also showed that reduced extinction learning before deployment, measured via use expectancy ratings, predicted PTSD symptom severity after deployment. Well, then I'm sure we all had the same kind of like wake-up call a while ago, where it really showed that it's very important to replicate findings. And this is already published in 2015, where the Open Science Collaboration showed that the findings that could be replicated were very low, and it's very tragically low, I would say. I think in social psychology, it was definitely worse than in the field that we are working in experimental psychology, but still, like, numbers around 50% of findings that could be replicated, I think that's not very good at all. So that drove me through to a next study, and this is a study that I talked about briefly about the soldiers, where I tested reduced fear extinction in soldiers. Has been published in Behavior Research and Therapy in 2013 already, so you can look it up. Well, when I started my job at the University of Groningen, I thought maybe I should try and replicate my own findings. So that's what I did. And it's slightly different in the setup. So I'll take you through the two studies right now. So I tested soldiers in the 2013 paper, which was consisting of 249 soldiers. Now in the replication study, I tested firefighters. So they're both high-risk populations, work-related, of course. There's a slightly bigger sample now, but also slightly different kind of profession, of course, but both high-risk professionals. Then the study design looks slightly different, because with the soldiers, I could test them before and after their 4-month deployment to Afghanistan. Whereas for the replication study with the firefighters, I just tested at some point, which I called the baseline, and I followed them up for 6 months and 1 year later, because of course I didn't really know when they were going through events. So I just had to pick a time point, which was very different from the soldiers who came back from their deployment. I could just test them just after coming back from their deployment. So with the firefighter study, my aim was to follow them up for 5 years, which is quite a long time, but we're almost 4 years down the line right now, so that's quite nice. Then the paradigm that we used was very similar. So we used the conditioning paradigm, where we used use expectancy as an outcome measure. So that was a cognitive outcome measure. And the only difference was the US that we used. So we used electrical stimulation in the soldier study, whereas with the firefighters, I used a loud scream combined with aversive pictures. And that was just because of practical reasons, to be honest. A lot of conditioning studies use a loud scream and aversive picture, and a lot of them use electrical stimulation. So far, there haven't been great differences. As long as the US is aversive, you can use it. Although even there's also studies showing you don't even need an aversive US. So it's also quite interesting there. But anyways, I don't think it would make a big deal changing the US. So who participated? There's you can see the map. That's basically the Netherlands divided into 25 firefighter regions. And we had the green areas decided to work with us. The red areas didn't. I don't expect you to know the topography of the Netherlands, but it means that basically we included most major cities in the Netherlands and also some more remote areas. So we had a nice representation of the kind of areas that we have in the Netherlands. We had 529 participants at the baseline assessment. There was a mix of volunteer and professional people, and also some of them, or quite a lot of them actually, were professional firefighter, but also volunteered on the side. The mean age was about 40, and you see a huge range from 18 till 61. So we had a nice representative sample in that sense. The years of employment were on average 15, but we had people who just started, so they didn't have any experience yet, up till people already going with for the pension, so they had 41 years experience. And we predominantly had males in our sample, only 27 women, which is also very representative for the whole sample of firefighters. And this is what a conditioning paradigm looked like. So we had pictures of people as CSs. So these may not look neutral to you, with the ones I picked for this presentation, but these were selected individually at an individual basis for which pictures were neutral for the participant. So one of them, these neutral pictures, was then in the acquisition phase combined or immediately followed by the unconditioned stimulus. So there was a loud scream through the headphones and a very not bad picture from the IPS system. So that was done 8 times, randomized with 8 times the neutral picture, which was not followed by the US. So basically we had the safety signal and the danger signal. At least people could learn that one picture was predictive of the US and the other one was safe, predicting the absence of the US. Then without any instructions, we went on to the extinction phase, where both pictures were again presented, but now without the US. So basically they could learn in this phase that the danger signal no longer predicted the US. And in the meantime, every time we presented the CS, we asked them, to what extent do you think this picture will be followed by the shock with this, not the shock, sorry, that was in the previous study, followed by the picture and the scream. So here it says definitely no shock, but it should say for this study, definitely no picture plus scream, and definitely a picture and scream. So that was the outcome measure here in this paradigm. So I'll briefly show the flow chart. It might be quite small in this screen for you, but basically what it comes down to, we had 520 people enrolling to this study. Not everybody completed the conditioning task because of a few different reasons. A few people dropped out because they found the US too aversive. We had a few people with where we had technical problems, and we had a few times that the emergency bell went off because we're testing them at the base. So then they just had to run to their van and go off, and we couldn't finish it that day anymore. So that's why we didn't have everybody participating in that. Then we had a 6 months follow-up, which was online. They filled out questionnaires online. And then we had a 1 year follow-up where they also filled out questionnaires online. We had dropout for quite a few people because, some people filled out the questionnaires at 6 months and not 1 year, or the other way around, or did both, or didn't do it either. So in the end, we used the data of both time points, and we had quite a few people who dropped out from the analyses because they did not experience any kind of firefighter-related potentially stressful event. And we thought, well, then it doesn't make sense to look at PTSD, right? And then we had a large group of people also being excluded because they were non-learners in the conditioning tasks. So they didn't learn the fear. So if you can't learn a fear, of course, you can't unlearn it. So if you're looking at unlearning, you need to learn it first, right? This is how I've done it exactly in the 2013 paper. So I wanted to keep that equal. So these are the results, and I just pasted them next to each other. They look very similar. So they look almost the same, but they're not exactly the same, as you can see, but they look very similar, which was also very nice to see. That means that we did find with the same paradigm, it didn't, provide any kind of real differences in that sense. So you see a very nice acquisition phase. You see the A on the axis is the A is acquisition, E stands for extinction trial, and then on the y-axis we have the use expectancies. You see that the danger signal, the CS plus, is indeed becoming a danger signal. I don't know whether you see my cursor here. during the acquisition, and the safety signal is nicely becoming a safety signal because it's not doesn't raise any use expectancies by the end of the trial and acquisition anymore. And the same happens in the replication study. Then the extinction, you see that the drop is very large for the CS+. So when we're not providing any USs anymore, the use expectancies drop also quite rapidly, and the CS- stay quite low. So what I did, I operationalized extinction learning as follows. I looked at the first 4 trials. So the steepness of the curve basically is for me a sign of extinction learning, or the rate of extinction learning. I used the first 4 trials because there's the major drop. For the 2013 paper, I also analyzed this more trials, including more trials. What you see is if you include more trials, the effect becomes smaller and insignificant, because basically also other studies show that basically the more trials you just provide, in the end, everybody will learn to unlearn the fear again. So it makes sense that the biggest differences are in the first bit. So I did exactly the same for the replication study, and I'll just share the results with you. So for the 2013 paper, I found that reduced extinction learning predicted higher PTSD symptom severity in the soldiers. This predicted value also remained after controlling for baseline PTSD symptom severity, neuroticism, and stress severity. So, higher risk factors for PTSD. So that was quite interesting. So it explained at least some unique variants in that sense. In the replication study, however, we found that reduced extinction learning did not predict PTSD symptom severity. And when I controlled for the other factors, for the other variables, the direction was even in opposite directions. Reduced extinction learning predicted lower PTSD symptom severity. I have to note that, usually I think if I would have done this analysis and I didn't find reduced extinction learning to predict PTSD, you probably wouldn't even go on to this next step and see whether, what happens if you put in covariates. However, I wanted to keep the analysis very similar, so I did do exactly the same thing as I did before. I have to say, though, that if you look at the correlations, that reduced extinction learning correlated very weakly with higher PTSD symptom severity at baseline in the expected direction, but it did not correlate at all with PTSD symptom severity at follow-up, which was quite unexpected. So my conclusion is that earlier findings of the 2013 paper were not replicated. Extinction learning as the only predictor in the model did not predict later PTSD symptom severity. And since the correlation between extinction learning and PTSD symptom severity at follow-up was not significant, perhaps not much weight should be given to predictive value that we found in the opposite direction when the other risk factors were included. I looked at this with a statistician and I asked her, how can I understand this? What is happening here? We tried several things. We couldn't find out. There's no interaction with the other variables. So it's quite a mystery so far. She also told me, explained me, it's very hard to find out where this unexpected result is coming from. But we tried the most obvious ones and it couldn't give us an explanation either. So I think the conclusion is that extinction learning might only predict PTSD symptom severity in combination with certain personal and environmental characteristics. So others than included in this study, obviously. As we know that something like PTSD is influenced by so many other different factors. It's not just one thing that decides whether you or predicts whether you get PTSD or not. And then because the timing of the assessments is very different between the studies, extinction learning potentially is not a good indicator of more long-lasting PTSD symptoms, but maybe it is for short-lasting symptoms. So for the soldiers, as I found the predictive values when I tested them immediately after their deployment, that's exactly the timing. If they would have had any kind of symptoms, it would have been then, right? For the firefighters, by the time I tested them, it's very likely like the traumatic event could have, or the stressful event could have happened in between 1 day and 1 year ago, basically. So there's a fair chance that by the time I tested them, if they would have had any symptoms, they would have subsided by the time I've tested them. So that's why I think the last conclusion might be very true. And in general, I think extinction learning might not be a general risk factor for PTSD for all individuals. So it seems to be that, because I'm not replicating my own findings, it seems to be that multiple factors are relevant here and influencing each other. So for future studies, sorry, the light is going off because I'm not moving anymore. Anyways, I'll just continue. For future studies, I think there is definitely a need for more prospective studies, which also include these various risk and protective factors to unravel these complex relationships. And, well, as I said, this is just one study, one thing that I've published, I'm trying to publish right now on this 5-year perspective study. Is much more coming from there because I included lots of variables, and I hope to get more insight in what is predictive of PTSD. So it's a bit of a cliffhanger. And I put this picture in when I talked about this study, because I applied for a grant and I got very far. I got to the interviews, got very good evaluations, but despite the good evaluations, I didn't get the money because it's very hard. It's only top 9% or so it gets it. I just didn't get to it. And I thought, because I had this plan with a firefighter study, and I thought, I want to do this. I planned it all already. And even though I didn't get the money, so there were obstacles, there were definitely doubters, and I bet there must have been mistakes during, I'll find out later probably. But with hard work, it feels like there's no limits. I managed to run it now for 4 years and have a pretty large sample still testing and well, participating in this research. So that's maybe a main message for everybody who has to deal with lack of money or not getting grants. It's still possible to run, studies or to run studies. And I also want to thank all the people already here for working with me, because I had loads of volunteers, like students who want to get experience with testing, but also some colleagues, and also even my parents were helping out with the testing. And I trained all of them, and they helped me out with testing all those firefighters across the country. So with hard work, you can get very far. That's also a message I want to get across. So this will be continued. It's a bit of a cliffhanger, but there's way more to come. So that's nice. Hopefully I can tell you more about it in another webinar. Who knows? All right, so I want to go on now to the second line of research, which is about pathogenic mechanisms. So about how of things. And one of the things I want to show you is one of study on guilt and PTSD, because PTSD originally classified as an anxiety disorder in DSM-4, right? An emphasis was really much on fear and anxiety, whereas we know that many more feelings are involved. So PTSD is now also classified as a trauma-related disorder in DSM-5, and there's more emphasis on these different negative emotions like fear, horror, anger, guilt, and shame. And I'm going to look more into guilt. So the concept of guilt, well, it involves moral transgression, the real or imagined, and in which people believe that their action or inaction contributed to negative outcomes. That's kind of a definition, or one of the definitions that has been given to guilt. But the direction of the guilt-PTSD relationship is poorly understood. So one of the models several models that have been put forward is, this one model where trauma predicts guilt and guilt then influences PTSD. And also the other model assumes that trauma actually predicts PTSD and then guilt is more a consequence of PTSD. The model 3 consists of guilt and PTSD both coming from the trauma directly, and there's another model where shame and depression is in between. What we did is test this first model where trauma leads to guilt and then guilt leads to PTSD, to test it experimentally. And I like to do experiments, but because I feel it's highly controlled, but it gets you get a chance to influence one factor, in this case guilt, and really find out what it does to your dependent variable, in this case PTSD. So we tested this in a non-clinical analog population. We'll let them face an analog trauma, so a stressor, of course. It has to be ethical, of course, what we do in the lab. And we manipulated the feelings of guilt and then test the occurrence of PTSD-like symptoms. I'll briefly show you what we did. So the analog trauma stressor that we used was a PC crash incident where the participants got blamed for the PC crash and a loss of data. And we had a student who was a great actor and was very distressed by what happened, by the PC crash, and was very afraid of the consequences it would have for him. And then, well, in the other condition, we blamed not participants for the PC crash, but we blamed a technical failure for the PC crash and a loss of data. So that's how we try to manipulate guilt. Well, our outcome variables were intrusions and related distress, so related to this PC crash. So in order to find out, to test it, we had an intrusion diary for a day for people, and they rated the frequency and related distress of actually everything that reminded them of the test session, but we only looked for PC crash related thoughts or images. So we had to come up with a cover story, of course, not to get into demand characteristics. So we said we want them to keep a diary to check changes on awareness of sustainable behavior after watching a video clip, which was promoting sustainability. And then for the PC crash, that was a cover story that we just said, we've got a typing task here for you to assess the influence of the keyboard designs on typing speed and accuracy. And then the instruction was to type in 5-letter combinations as quickly as accurately as possible and not press the Alt key. That was very specifically, and then we would actually get a PC crash. So this was the design. We had baseline measures of emotions at first. Then we had a cover story with the film and then about sustainability and the typing task. And then the typing task would then lead to a PC crash, which looked very real, to be honest. And then in one condition, the participants got blamed, and they said, "Well, we said you couldn't press the Alt key. You actually have pressed the Alt key. I can see it here. It's your fault that it all crashed." Blah blah blah. Where in the other condition, the participants were not blamed at all. But as I said, it was we blamed the computer or technical problems. And then we kept an intrusion diary for one day. And we tested the emotions again after that, after one day. So here you see the manipulation check. So feelings of guilt were here. And you see that the blame group showed an increase in guilt after the manipulation, which already also went down after one day, which you also like to see for ethical reasons, of course. But you did see the increase there, and there's a significant interaction. So no increase in the no blame group. So it was great. And interestingly enough, if you look at the number of intrusions and the distress caused by the intrusions, you see that there was a significant difference between the groups, with the blame group showing about almost 3 intrusions about the PC crash, and no blame group close to 0. And the distress related to these intrusions, if they had intrusions, was 6 on a scale from 1 to 10 for the people who were blamed, and not even 1 for those who were not blamed for it. So to wrap up and discuss the conclusions, feeling of guilt as a reaction to a stressor were related to a higher number of stressor-related intrusions and higher associated distress. So guilt might contribute to the development of PTSD symptoms, such as intrusive thoughts. Of course, this is not a clinical sample, so we need to find out whether this generalizes to clinical samples, but it does say something about the mechanisms involved, and they don't seem to differ between analog samples and PTSD samples. So the clinical implications could be that potentially there should be more importance of attending to at least feelings of guilt in PTSD besides feelings of anxiety. It confirmed the recent trends not to look only at anxiety. All right, so this has been published in European Journal of psychotraumatology, and it's open access, so you can just read it. It's called The Role of Guilt and Post-Traumatic Stress Disorder if you want to read more about it. And now I want to briefly go into interventions. And some of the work here is not directly related to PTSD. We are running some trials. I'll tell you more about that in a bit. But I would like to show you the idea about looking at these elements of treatment. And this is our PhD student, Rachel de Jong, and she is looking at different ways of practicing exposure therapy. So this is done at the DARE clinic. We started this DARE clinic here in Groningen and different places in the north of the Netherlands, where we treat children with a specific phobia. And one of the questions we wanted to answer is whether it matters whether you start with, we have a fear hierarchy while doing exposure therapy. Does it matter whether you take small steps or big steps? And as for different theoretical angles, there's different expectations about that. So I don't want to spoil what it's a bit of a spoiler, but it doesn't seem to differ actually. But it still needs to be published. So this will be published hopefully soon. So that's why I won't get into it in detail now, but I'll go into another study about it's called Talk Like That. It's a study on speech anxiety among youth, and it has been published in Behavior Therapy, also available online. And what they did, like, basically want to restrict the limited time for the time that we have in therapy to the necessary treatment components only. And the question is, what an exposure therapy is actually necessary. A lot of people use exposure, like, right? And there's also evidence that exposure earlier in treatment leads to better outcomes, and that more exposure in treatment leads to better outcomes. But there's also a lot of other techniques that have been used. For example, relaxation. And for relaxation, there's different mixed evidence whether it's good or not. So it has been shown that relaxed patients experience less fear during exposure, and relaxed patients show less avoidance during exposure, which might benefit the outcome. However, there's also signs and some evidence that relaxation can become a safety signal or safety behavior, and that the focus on physical sensations increases fear, which might not be good for the outcome. And then cognitive restructuring is often used combined with exposure therapy. And again, there's mixed findings about the usefulness of this. So on the one hand, cognitive strategies reduce the expectation of the fear outcome. For example, with related to speech anxiety, no one laughed at me, but I expected it already, right? But it could also be, you could also see it as well, the reduced expectation also decreases the surprise effect and mismatch. Well, that's critical for learning. So no one laughed at me, which I did not expect at all, might actually be really good for exposure. So there's different arguments to be made about this. So what we did is to test whether exposure-only training would be more effective in reducing speech anxiety than exposure combined with these anxiety management strategies. So we tested 65 children or youth, basically, in the age of 12 to 15, mainly girls, and they all scored high on speech anxiety, where the screening, then a pre-assessment, then the training, then a post-assessment, a follow-up, and we included clinical interviews, speech tests, and self-report measures. So this is what it looks like. In one group, they got psychoeducation, then 4 sessions of exposure. In group 2, so they were randomized, right, to psychoeducation, then cognitive restructuring, then exposure, and the other last group was combined relaxation and exposure. And these are the results. So basically, the good thing is that everybody showed, or not everybody, but in general, there was an improvement seen in speech anxiety. So 40% was below the norm for speech anxiety at post-treatment, half of them at follow-up, but there was no meaningful differences between the groups. So that's also quite interesting and good to know, of course. But it also says that devoting all sessions to exposure is as effective as combining it with anxiety management strategies like cognitive restructuring and relaxation. So relaxation and cognitive restructuring are not necessary, although in clinical practice, a lot of people think these are necessary. So in our study, they showed that they're not necessary for CBT to be effective. They're not necessary for adolescents to tolerate the exposure, and they're not necessary to directly tackle thoughts or feelings, because these thoughts and feelings got tackled also by exposure alone. Of course, this is a limitation that we only had the effects on a group-based format. So, you know, it could be that exposure, because all the groups had exposure, that exposure itself, these 2 sessions was already, you know, enough for all the groups to improve. We're not sure about that. Anyways, but it does. I do think it has a very important clinical implication. All right, that's what I wanted to share. Now I want to share a few new projects that's coming up. So this is an external PhD student who's just started. We got a grant for this. He's a psychologist at a trauma center. His name is Rick de Haart, and he's going to look into avoidance as a predictor of PTSD treatment trajectories. And he's also going to look at the effect of movement during trauma-focused therapy on treatment outcome. So I don't know what about Mexico, but in the Netherlands, there's a huge increase in interest in using movement, exercise, sports to augment the effects of trauma-focused treatment. And there's not a lot of studies yet that should really show that it actually augments the treatment outcome. So this is one of the things that we're going to look at in our study. Very excited about that. We've started this. So there will be some RCTs, some clinical studies, and some lab studies as well. All right, and then finally, I just have like 5 minutes left, I see. I do want to dedicate this to the cross-cultural clinical psychology domain that I'm very interested in. And I want to also show you my colleagues, Professor Theo Bouwman and Professor Judith Daniels, who with me are working on these kind of projects. And we've got a nice collaboration set up with the University of Gajah Mada in Indonesia and with Tapar University in India. And I'll show you one of the projects that we are, currently submitting a paper about, and that's about acceptability of cognitive behavioral therapy in Indonesian community healthcare. So what we did basically is we created a few videos about CBT, cognitive behavioral therapy, and then more related, not so much on one kind of diagnosis, but more transdiagnostically, show a couple of interventions, CBT interventions that you could apply to basically all psychological problems that you come across as psychologists. And then these were translated and also adapted to an Indonesian version of it. So instead of seeing Dr. Theo Bouwman or Professor Theo Bouwman and me in the video, these were now very nicely adapted to an Indonesian version, where you see our colleague Diana Setiawati there with her research assistant showing these videos. And then we tested whether these were, acceptable for people who work in the Indonesian community healthcare settings. And we did a study on this, and it showed that people found it very acceptable indeed. So it was very encouraging. So here I have to leave the building within in 15 minutes from now, but that's okay. We still have some time. And then, fingers crossed, that's my my final slide. Hopefully, we can start a new project very soon, and that's a double degree program with Alejandrina Hernandez, who's hosting this as well, in collaboration with Professor De La Rosa Gomez, who introduced me very nicely as well. So I'm very excited about this project, and will be on transdiagnostic factors in depression and post-traumatic stress disorder in both the Mexican and Dutch population. So really fingers crossed that we get this funded and we can set up this and continue this collaboration. All right, so thank you very much for your attention, and I'm very happy to receive any questions from the audience right now. So I'll stop sharing now.
Well, thank you, Dr. Lommen. That was very insightful, especially the importance of applications of studies and cross-cultural psychology. We are receiving some questions and comments from our audience. We have a question that says, regarding the non-replicated findings, Were the baseline differences, for example, sociodemographic variables, early adverse experience between the two studies that may be moderating the result?
Yeah, these are very good questions. I haven't checked everything yet, to be honest. But on a lot of factors, they're actually quite similar. So I did have this suggestion from somebody else as well, that maybe the firefighters already had more events than the soldiers, and it was not the case. They're both very exposed. So most of the soldiers, like half of the sample, has been on deployment before, and for the firefighters already had a lot of experience. Of course, if you looked at in the general level, both samples consist mainly of men. Maybe it's slightly younger though in the sample of soldiers, but I didn't find age to be related to PTSD symptom severity. So yeah, that's also not really an explanation. So I looked at several things. I couldn't find anything that explains it, but of course there might be other things that I have not measured that could explain this. But it's a very relevant question. Yeah.
We also have people interested in being part of your research. We have many comments about the possibility of replications of the study in other contexts and vulnerable populations, for example, in underdeveloped countries that have suffered trauma and other types of violence.
Yeah, I think that would be great. I mean, definitely, I would only encourage replicating results in, especially if you can do the same paradigm in different countries, different groups of people, different patient groups, or like inpatient group even, or different kind of populations. I think the more we use the same paradigm in the same kind of groups in different places, different populations, the more we can really understand what's going on and how important this factor actually is.
We also have a question that said that somatic reaction can also be the habituation before of the stimulus.
For a stimulus, I don't think so, because people actually, we asked them after the paradigm how aversive the picture was and how aversive the loud noise was, and also the combination of it. And it was, people say that it was really quite aversive. I don't know the numbers now by heart, but they didn't like it at all. And also knowing, because I did a lot of testing myself, a lot of people were so done, they even got more irritated by the sound and they really wanted to get rid of it. So I don't think habituation to the US could explain the deep curve in there. And yeah, so I don't think it's habituation, no. But it is a fair question, definitely.
Okay, I think we have time for one last question. When PTSD has become chronic and the body's function, automatic responses are hypersensitive, what will be the possible intervention to erase these bodily memories?
That's a very interesting question. I know, as a psychologist at least, I know that these bodily reactions usually also disappear if you do exposure therapy. So at least trauma-focused therapy would also lead to decreases in these kind of bodily symptoms. However, it is true that these are a bit more, let's say, sometimes it takes a little longer for these symptoms to change. So you will first see changes in intrusions, in the intrusion cluster, and less so in the physical symptoms that people complain or have, or like concentration problems. Those kind of things take a little longer, I think. But in the end, I think these changes, they also change, but it just takes a little longer. And maybe if you think that the trauma-related therapy is successful, but they still have some kind of other symptoms left, like bodily symptoms or complaints left, I think it is good to think about other interventions that might be specifically related to that kind of complaint to see whether we can help that with another intervention. But in general, I think, yeah, for a lot of people at least, the trauma-related treatments also help for these kind of symptoms to subside. I hope that kind of answers the question.
Yeah, thank you, Dr. Lommen. Unfortunately, the time we have is limited, and however, you can contact Dr. Lommen for more questions on the subject and to follow her lines of investigations. I would like to thank our audience for being present and for the comments and questions. And once again, I would like to thank Dr. Lommen on behalf of our audience and the UNAM community for having accepted our invitation, for joining us for this webinar session. I don't know if you have any last comments.
Yes, I want to thank you, and of course, well, I want to thank you for the nice hosting of this and making it such a pleasurable experience, and again for the invitation, also to Professor La Rosa. And I also want to encourage people, if you're interested in this and they want to collaborate, I'm very open for collaboration. It would be great to have collaboration all over the world. I always, well, I really enjoy that, and I think it's a way forward. So thank you so much for hosting this and for having me.
Well, thank you, Dr. Lommen, for the presentation, for our invitation. And hopefully we will be seeing you soon.
Yes, definitely, hopefully, definitely. All right, and sorry, I also have to leave because I have to leave the building. We're going to close in 5 minutes, so I have to go out. So I'm sorry for this abrupt ending, but we'll hopefully see each other soon again.
Thank you. Bueno, y muchas gracias a nuestros invitados. Y antes de despedirme, quería invitarlos a la próxima sesión del seminario web, el 23 de agosto, a las 10 de la mañana. Tendremos invitados a la doctora Paulina Elena Grave de la Facultad de Psicología con la ponencia de promoción de la salud mental y prevención del suicidio en contextos clínicos comunitarios. Muchas gracias por su atención. Thank you, Dr. Lommen.